This is the Burrell College of Osteopathic Medicine's regional conference in 2021. The topic of our conference is breaking through barriers in healthcare and learning. My presentation is post-COVID fatigue syndrome. Quarantine after exposure has meant that the vast majority of people infected with COVID-19 virus have not been examined throughout the course of their illness. We have a huge barrier to overcome. It is our own distance from the patient. When patients come in with post-COVID fatigue, we won't be able to assess and help them unless we break through the biggest barrier and examine the patient with our hands. Osteopathy is based on palpation, and today I'm going to be happy to introduce you to a bit of osteopathic history. Three heroes: Andrew Taylor Still, the founder of osteopathy; William Garner Sutherland, the founder of cranial osteopathy; and Jean-Pierre Burrell, the founder of visceral manipulation. And then I'll tell you the story of the work I've done this last year in finding patients who've been suffering from post-COVID fatigue syndrome and following it three seriously ill patients through the long-term course. We have a problem that really requires us to examine the patient. Post-COVID fatigue syndrome does not match the average chronic fatigue syndrome. According to the NIH Clinical Spectrum Report of April 24, 2021, 26 to 87% of people who have had mild or moderate COVID symptoms have persistent disabling fatigue, muscle weakness, joint pain, chest pain, shortness of breath, cognitive impairment, and worsened quality of life. Cardiac MRI studies in Germany revealed persistent organ dysfunction in 78% of the patients at a median of 71 days after diagnosis. Myocardial inflammation was ongoing in 60% of these patients. Like it or not, we have to break through the barrier and examine the patient with the tool that makes us human, our hands. With the information of the physical findings, we learn how to ask the right questions at the right distance from the patient to get the right answers about the level of behavioral impairment that correlates with the structural dysfunction. Little background on me: college education, Harvard College, Tufts University School of Medicine, Charity Hospital in New Orleans, the New York Hospital for Residency, University of New Mexico, Child Psychiatry Fellowship. I was faculty at the university from 1984 to 1999. I've been in private practice for the last 22 years, and my area is osteopathic child psychiatry, with particular attention to adrenal function and white matter structures in the brain. My name is Daniel Kerlinsky. I want to thank the students of Burrell College of Osteopathic Medicine for bringing me back to the world of teaching after 20 years in private practice. Thank you also to the Burrell College staff, scientists, faculty, and administration. And a special thanks to all the preceptors for giving your time to the students. New Mexico will benefit from the osteopathic medical approach. Today, I'm trying to bring together the fundamental medical skill of palpation with the most advanced molecular biology and biophysics we have ever seen to help us grapple with COVID. A biophysical finding on exam, remarkable stiffness, heat, and hardness, set me on a search to find from preclinical and basic science research what aspect of COVID could make such stiffness happen so early and so persistently. Objectives are a little bit steep. Participants will be familiar with 4 symptoms of post-COVID fatigue syndrome. Participants will remember a billable ICD-10 diagnosis code and 3 physical examination signs of post-fatigue syndromes. Participants will remember having seen 2 steps of osteopathic Fulford chest percussion, followed by osteopathic visceral manipulation for residual lung, rib cage, heart, pericardium, liver, and frontal lobe stiffness. Participants will consider whether there is enough evidence about cell-to-cell fusion, syncytium formation, and polymerization of viral protein, collagen, or actin to warrant investigation of whether spike effects independent of viral replication are need investigation. Finally, in the absence of proven pharmacological treatments for post-COVID fatigue syndrome, participants will have considered whether restrictions should be placed on physicians discussing or prescribing low risk and higher risk therapies. For example, starting with low risk, L-glutamine, an amino acid for energy, motivation, memory, gut epithelial healing, and immunity might be considered. 5-hydroxytryptophan, an amino acid for energy, motivation, for anxiety and emotional dysregulation, an herb pomegranate extract for vascular endothelial inflammation, and then compare the side effect risks of these amino acids and herbs to psychostimulants for focus, apathy, and discouragement. We do have a study showing it works for chronic fatigue, 10 milligrams morning and afternoon. Antidepressants, including monoamine oxidase inhibitors, which are higher risk, hydrocortisone for diurnal and epigenetic re-regulation, which has had some success reports in the past and complications, or my favorites, minocycline for central nervous system inflammation, or clemastine for oligodendrocyte remyelination. A quick review. Neurological and psychiatric systems have been reported among patients who have recovered from acute COVID-19. High rates of anxiety and depression have been reported in some patients using self-report scale. Interestingly, we may see younger patients reporting more psychiatric symptoms than older patients. Patients may continue to experience headaches, vision changes, hearing loss, loss of taste or smell, impaired mobility, numbness in extremities, tremor, myalgia, memory loss, cognitive impairment, loss of higher executive functioning, and mood changes for up to 3 months after diagnosis of COVID-19. One detailed study in Ireland of people who had recovered from acute COVID-19 used the Chalder Fatigue Scale, CFQ-11. More than half the patients, 52%, reported persistent fatigue at a median of 10 weeks after initial symptoms first appeared. Listen again. There was no association between illness severity and long-term fatigue. An outpatient service for patients recovering from acute COVID-19 in Italy reported that 87% surveyed reported persistent symptoms at a mean of 60 days after symptom onset, with the most common symptom being fatigue. This is me with my usual subject of most interest, the skull and central nervous system of children. I came to New Mexico in 1982 for a 2-year child psychiatry fellowship at the University of New Mexico. I'm an MD, mostly concentrating in psychopharmacology, but after my first osteopathic craniosacral course, I was fascinated to find palpable interface between body and mind. Since then, I've taken 1,200 hours of osteopathic table training. One needs to be shown how to palpate. And osteopathic evaluation is part of my initial eval. Optimal neurodevelopmental progress for children requires cranial osteopathic treatment. This requires stopping inflammation in the central nervous system and restarting myelination. I see my patients regularly, most often once or twice a month, and I take care of about 250 families. In my patient population, inflammation and demyelination start at birth. Table work, not tranquilizers, is my best crisis intervention. As the COVID pandemic proceeded, I decided to keep on working. I expected to find common indications of mild liver inflammation early in a viral illness, but it wasn't there. The liver was soft. What surprised me was the uniform hardness of the rib cage and the lungs, and the uniform hardness and hotness of the frontal lobes. The frontal lobe findings were so stiff that none of my osteopathic cranial techniques worked, and I had to treat the stiffness in the rib cage and chest in order to be able to then make progress with the cranial therapy. My teacher and mentor, Frank Lowen, taught me to feel layer by layer into the organs of lung, liver, heart, and brain. I had never felt such hardness so quickly and so uniformly around the 3 organs at once: heart, lungs, and brain. So what did I do? I took out my Fordham percussion hammer and went to work on the rib cage. The Fordham percussion hammer was introduced to osteopaths by Robert Fulford. It took me about 10 to 20 minutes to make some progress with a stiff rib cage and stiff lung. And I also did some techniques to help the patient inhale more deeply into the front and back of the lungs. Then I was able to go back and release the swelling and the sutures and the stiffness of the cranium and relieve some of the heat in the brain. So pay attention here. If you remember nothing else, this illness is in the body and the head. It has a billable code, G99.3, post-viral fatigue. Make a habit of tracking approximately 4 patient complaints in your notes. Use the physical exam to verify the condition and guide your assessment of progress or relapse. Practice a standard method of palpating lungs, heart, and cranium. I'm going to take a little side break here to some of the exciting science. This is probably the first pictures you'll ever see of the spike protein in green making contact with the angiotensin receptor in magenta. This was just recently published by a group out of Princeton at the end of April. You can see on the left, here comes spike protein. It seems like spike and Angie are almost friends with that first kiss. And then suddenly the fusion begins in the third picture over. And in the fourth picture, where the green has merged into the purple dye that was fluorescently illuminating these proteins in a human culture in vitro experiment, something very frightening is it looks as if the spike protein is engulfing and fundamentally doing something we don't see from the nice diagrams of what proteins look like. Here's the group. Department of Chemical and Biological Engineering, Princeton University, David Sanders, and Clifford P. Brangwyn, who's the leader of this interdisciplinary project. SARS-CoV-2 requires cholesterol for viral entry and pathological syncytia formation. Remember this, syncytia are a defining pathological feature of COVID-19. Given the cytotoxic consequences of cell fusion, syncytia with COVID and angiotensin involved is not a stable fusion like the fusion of heart muscle cells or the fusion in the placenta of cells. Given the cytotoxic consequences of cell fusion, an appealing hypothesis is that the angiotensin spike-mediated cell vacuolization, which you'll see in a minute, contributes in part to the diffuse alveolar damage observed in the lungs of COVID-19 patients. Interestingly, COVID-2 spike is a particularly potent mediator of syncytia formation relative to both SARS-CoV-1 and many other commonly studied fusogens. You're going to see something here you probably won't see anywhere else. Stage 1, small syncytia. So the spike protein here is the magenta. The green are the cells that are being attracted by the spike protein. Here we have almost 20 green cells being adhered and pulled together and fused by the spike protein. And we'll see in a little bit that adhesion molecules, which create stiffness, are also involved in fusing these cells together. After a short period of time, this was called vacuolization. So inside the cell, at a degree and three-dimensional view of a movie that was taken, we can see these little buds, these round vacuoles beginning to show the deterioration of the cells that were fused by the junction of the spike protein and angiotensin. And here comes the next step. It seems like the cells have exploded all at once. The structure that was so tight, fusion, has now turned into a disruption. Here's what the group said. Spike protein resembles 4 human spike-like proteins that they search for amongst everything in the microbiology and the molecular biology, critical to forming adhesion junctions. So it looks as adhesion junctions, very tight junctions, is part of what creates the stiffness that we're able to palpate when we're examining rib cage, lungs, heart, and brain. Inspired by the synapse-like structure observed in living cells, we asked whether spike features amino acid motifs similar to human proteins. Remarkably, all the top 4 proteins that resembled spike were critical to forming specific types of adhesion junctions. 3 to tricellular tight junctions and 1 to kidney intestine tight junctions. So I'm going to introduce you now to my heroes in osteopathy, Andrew Taylor Steele. Dr. Steele was born in 1828 and died in 1917. The son of a physician who was also a missionary who opposed slavery, Andrew Taylor Steele grew up hunting in the woods of Tennessee and Missouri before the family moved to Kansas. He was elected to the Kansas legislature in 1857 already practicing as a physician. He was a bold opponent of slavery, but it was his skill as a physician that saved his life on more than one occasion when surrounded by pro-slavery militias while he was riding his mule back and forth from house calls. Captured by a Confederacy militia, the leader allowed him safe passage, declaring, "In politics, he is our enemy. In sickness, he is proven to be our friend," stated Captain Owens. Autobiography of Andrew Taylor Still, page 65. As a younger man, Dr. Andrew Taylor Still founded the American School of Osteopathy in 1894 in Kirksville, Missouri. Although Dr. Still was fascinated by the mechanics of bones, he understood that recovery from illness depended on restoring optimal circulation throughout the entire body. From his autobiography, "You know the course of an artery, nerve, and vein, and before you take your hands off your patient, you should know that you have removed every obstruction to the nerve, the vein, and artery, which gives force and nourishment to the depleted locality. When you are dealing with a diseased liver or any other organ or part of the body, remember the highest officer in command is the artery of nourishment, which must be assisted by the nerve of motion and the vein of renovation. Use force enough to remove all obstruction. Be careful that you do not bruise any of the delicate parts." William Garter Sutherland graduated from the American School of Osteopathy in the class of 1900. He brought a radical understanding that the clockwork motion of 22 paired skull bones creates a bellows to pump oxygen into the brain. Here's his graduation photo from the class of 1900. Sutherland discovered an involuntary movement of the sacrum within the ilium, a wave of cerebrospinal fluid moving up and down the spine, and an intrinsic, involuntary, elastic, contractile curling of the brain hemispheres. After 40 years of analysis, palpation, and clinical success, Dr. Sutherland published a remarkably short 130-page introduction to his work. In a footnote on page 54 to 57, Sutherland describes how he developed his understanding by experimenting on himself. A remarkable introspective ability was what allowed him to perceive the effect of inhalation on cerebrospinal fluid motion. In the cranial book, he allows a lot of specific mechanisms of how the reciprocal tension mechanism of the falx and the tentorium keeps the skull in shape and limits its widening and narrowing. He reported details of how jamming the base of the skull, the temporal bones occiput and sphenoid, leads to profound disturbances in cognitive and emotional processing. He also had findings about how the hemispheres, brainstem, spinal cord, temporal lobes, and other components of the central nervous system have particular patterns of motion. Based on Dr. Sutherland's discoveries, there are now over 100,000 practitioners of craniosacral therapy. Our third great founder of the field of osteopathic therapy is Jean-Pierre Burrell, born in 1945, still present, author of 17 books he named Visceral Manipulation. Dr. Burrell first discovered how organ disease affected the spine when he was a young physiotherapist. He then attended the European School of Osteopathy in England and opened his practice in France. Dr. Burrell named the subtle intrinsic rotation patterns of visceral organs motility to distinguish it from mobility of an organ when pushed to assess its range of motion. He describes listening for tension or density, which tends to pull his hand towards the area of difficulty. The concept of osteopathy is mobility, to restore mobility to the body. Everything is moving. Every cell is important in the body. So to decide in advance what is important in the body, no, we cannot decide. Interviewed in Osteopathy Today in March 2013 in Britain, Dr. Burrell described his work like this. I use a lot of listening, which means you put your hand on the body and your hand is attracted to the tissues, which have a density or express a tension, and then it is up to your medical knowledge to know what kind of tissue you have found. For me, it's not so important to interrogate the patient. I prefer to let the hand give the diagnosis and after, of course, complete the diagnosis with the case history and medical background. So I feel first and think after. Dr. Burrell says, if there is good circulation in the tissues, we can work on retraction, fibrosity, the vascular system, and we have a lot of techniques for the arteries and nerves. Normally, a good tissue is supple. It has good circulation. There is no tension. When you put your hand and you feel a tension, it means there is something which doesn't permit this tissue to be in good health. Asked a final question, when you put your hands on a patient, what do you feel? Quote, you try to identify what tissue you are feeling. Is it a capsule, cartilage, bone, nerve, artery, fascia, etc. So you try to understand what kind of tissues are suffering underneath your fingers, and you treat this tissue. My mentor, Frank Lowen, born in 1948, met Dr. Upledger in 1983 and Dr. Burrell in 1985. He organized, designed, and taught hands-on seminars for them that became very successful across the United States and around the world. He's been a teacher of teachers for 35 years. His book, The Roots and Philosophy of Dynamic Manual Interface, involves describing some of the techniques of using two hands. Dr. Frank Lowen was the director of Dr. Burrell's Visceral Manipulation Program at the Upledger Institute from 1990 to 200. That's where I met him and took all the courses that he offered, including practical integration of visceral manipulation, where I was first introduced to recognizing whole body patterns of compression, collapse, weakness, and compensation. Well, let's go to our video. This is the Fulford percussion hammer. It has a very delicate adjustment process for the speed and a very small up and down motion, which actually facilitates all sorts of connective tissue release in the body. It's got about a 3/4 inch rubber pad, and when we're using it, we'll place the back of our hand against the body and then adjust the frequency just till where the rib cage or bones begin to vibrate. It's an $800 tool, so if some of you want to invest $35 instead and have a percussion hammer or a number of them available in your office to use or for the students to use, I recommend this model, Fascial Gun CY801. It's about $35 on Amazon, and it has the most gentle vibration compared to the other fascial guns, so it's more suitable for working on the chest and rib cage. So to put some cushioning on these hard rubber balls, we can take a fun noodle and place it on top of the hard rubber ball, and then just tape it on to give more protection. Or instead, you could just use a piece of foam on the rib cage in front of the hand. So in my ordinary course of treatment, I'll often be at the head of the table, just feeling the patient's head. It's something mothers often do, checking on children with fever. I have one palm on each side of the frontal bones, and the first thing I'm checking is for heat, stiffness, hardness, and swelling. Then I slide my right hand out laterally towards the right ear and see how much give there is. The give's not just the skin and the scalp. There's also the periosteum, there's the bone, and there's the connective tissue of the falx cerebri that the frontal lobes are hanging from. I'll roll laterally on the left side and I'll compare. Then I'll push towards the center and see if we have any give. An end-range feel of a little bit of elastic bounce. And we'll lift upwards and downwards from my palm of my hands backed by the coronal suture. We'll just lift up a little bit and see how much heat's coming out between the frontal bones and the parietals. So if I found my patient and there's some ordinary heat, tension, and hardness, I'll go, let me see if I can do a little bit of cranial technique and release that. With patients who are coming in with post-viral fatigue syndrome that happens to be post-COVID fatigue syndrome, we can't move anything at all in the frontal bones. That was the first sign that there's something wrong that's more serious. It feels hard. When we come down and check the liver, usually we're using two palms on the bottom of the rib cage and we're leaning up and in to the rib cage. And if there's some flexibility, you can feel the liver underneath, sort of like a brake pad on a bicycle wheel. We push in, there's a little bit more of a give, and that's a healthy liver. And check both sides. So a hand can go all the way underneath, and we can slide this hand in and roll a little bit to check liver mobility up to the diaphragm. To check the lungs, we just come up higher along the lateral chest wall up towards the armpit, and we push in. From the upper rib cage, we'll push in, but we get more information when we put two palms underneath. And first try to lift your lower palm to lift the bottom of the ribs. If the bottom lungs are tight, this won't lift at all. We lift the top of the lungs. If the top of the lungs are tight, it won't move at all either. And that's our first clue. You can't do this kind of exam with the patient sitting up because you need the weight of the patient's body onto your hands in order to judge how much spring there is or isn't. So once we find stiffness, early on it's all in the lungs, uniform stiffness. Later on, as the patient's recovering in the post-infectious period, the liver will get harder and harder relatively in comparison to the lungs. So we actually get more information on the lungs if the patient will turn into a sideline facing towards the left. Yeah, that gives you a little pillow here. Lift your head up, turn back down. So this is the most effective examination and treatment position. We have both hands, back of the ribs, front of the ribs, and we can squeeze and we lift up, which is the direction the ribs run, and we see how much give there is. And wherever there's stiffness, that's where we know we need to begin our treatment. So we have a little bit of stiffness at the bottom of the right lungs and a little bit in the liver on the right side. It's more apparent in sideline. Treatment's relatively simple. Adjust the frequency of the vibration to what will make the rib cage resonate. And then one hand behind the ribs, the other on the side or the front of the rib cage. We'll work our way up and down. The percussion hammer, because it's going vertically, rectilinearly, straight up and down, we can point it like a flashlight. And we sort of catch the vibrations with our hand on the other side, which reflects it back and makes it a stronger treatment. A sort of standing wave gets created. Down around the liver. We can come up above on the top of the rib cage just below the collarbone, or bring the hammer around the back. And be more thorough. The thoracic spine is often stiff in many kinds of chronic fatigue. According to Dr. Perrin, Perrin, an osteopath in England that's worked out a successful 2-year program for helping people overcome chronic fatigue. So part of our treatment can include vibration along the thoracic spine. Now turn back on your back. After even just a few minutes treatment, I'll come back to the forehead and the temperature will have cooled down already. I'll try to slide the frontals lateral, medial, posterior, inferior, and we'll have better glide. Even a little bit of compression will show us that there's less hardness than there was before. If hardness persists, we'll take the percussion hammer and put it on the shoulder and put our hands where we feel the bone the most tight. Here's near the left frontal sinus. And we'll get vibration indirectly to the opposite frontal lobe and frontal bone. Another location is the sternum. And if we're in a difficult case where nothing's going to respond, we actually can put a little bit of vibration onto the chin and use that to help release tension, tightness, and swelling in the cranium. After treatment, the patient usually feels like they can breathe better, lift your shell better. So our first technique of Dr. Burrell's is to put both palms under the lungs. And then I'm rolling the skin, the muscle, and the rib cage towards the spine. Inhale deeply and inhale into my hands in the back of your lungs. And hold 2, 3 and let it go. Good. Inhale to the back of my lungs. Push your rib cage into my hand. I'm sliding the rib cage and the lungs further towards the vertebrae. Let it go. And then one more time. Inhale. All the way to the lungs. Good. Now, to roll the lungs in the other direction, we want to imagine that the lungs are actually hugging the heart. So I'll start rolling the rib cage and the lung towards the midline, towards the heart. Inhale into the front of your chest. Lift, lift, lift. Imagine hugging your heart with your lungs. And let it go. And one more time. Inhale into the front. Imagine you're hugging the heart. And let it go too. And inhale. Okay, so close your eyes and take a deep breath and see how your breathing feels to you. What do you notice?
It feels very full, like I can breathe fully.
So when COVID goes further beyond the lungs into the pericardium and the heart and the diaphragm, we usually have tension right across the sternum. Dr. Burrell's technique for feeling the sternum is to put 2 hands on top of each other. So we can slide a little bit left, slide a little bit right. If we apply a twist, clockwise or counterclockwise, we can see how much connective tissue tension there is around the pericardium and the mediastinum. We'll usually release the pericardial ligament to the vertebral column from one hand front and back. We can release the ligament between the pericardium and the sternum again, one hand front and back. There's a connection between the pericardium and the aorta under the right collarbone, and we can twist. The direction of the heart contraction is up and spinning. What happens when we lose those movements can be part of what's most serious in this stage of mild to moderate coronavirus or post-COVID fatigue. And then we'll check the diaphragm. So inhale and try to pull your heart down as you use your diaphragm. Good. And hold 2, 3. Let go. Good. And one more time, inhale down. Diaphragm pulls down, pulling the heart with it. And let go, 3. When the heart itself is involved, the adhesion molecules that follow this sort of exudative process that leads to stiffness around the lungs, the frontal lobe, gets into the 4 chambers of the heart. And at that point, we divide the chest into 4 quadrants. And we'll go up and to the left, up and to the right, down and to the left, and down and to the right to try to see where the stiffness is. When we find stiffness in any quadrant, we'll hold on, we'll lean in just a little bit, and then we rotate our hands and try to put an even, steady pressure with the hands. The body is a piezoelectric phenomenon, in part because collagen is piezoelectric. They've even put collagen on cotton paper and generated electricity by changing the shape of the collagen structure. So we'll get our hands into position, check left, right, up, down, rotate, rotate. And when we're finally connected, it's like we've giving a magnetic field information to the body. After the percussion hammer's given lots of information off and on, we're going for a steady field effect. And then we'll check again, left, right, up, down, diagonal, 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 diagonal. And spring to release. Okay, close your eyes, take another deep breath. Lift your knees up and put your feet flat on the table. And rock your knees side to side. About 10 times. And then grab your right knee with your hands and pull it towards your chest just a little bit at a time. And release. A little bit and release. This is our way of stimulating the adrenal glands by stretching behind the kidneys. And back down. And take a deep breath. And exhale. Do you feel any sensations inside your body?
A little bit. It feels relaxed.
So we've just added engaging the adrenal system, and relaxing the adrenal system goes directly to the hippocampus in the brain. It helps take down stress in a number of different ways. Thank you very much.
I'm sorry.
To wrap up the program, let me give you a summary of one case I've been treating for a whole year for COVID-related symptoms. 54-year-old woman with obesity, diabetes, and hypertension, seen weekly in therapy for PTSD and depression. Onset with loss of smell in March 2020. Progression of signs and symptoms until the end of June. Dyspnea, chest pain, exertion fatigue, memory loss. She had a coronary angiogram for chest pain, which turned out to be negative. Post-COVID signs and symptoms can come and go. Percussion therapy and visceral manipulation in 6 treatments gave her a 6-month improvement. But at week 24, detachment and the feeling of fatigue presented itself again. Examining the patient, I found stiffness of the chest wall and tenderness around the heart. There was excessive heat and hardness of the frontal bone. Treated again with 3 sessions. She made some gradual progress, but now, 6 months later, she's still weak She has difficulty completing tasks, and she wakes up every morning with an anxiety that she had never known before. Let's go back a little bit to the medications issues. Cell-to-cell fusion is well established now in basic research, and syncytium formation, which creates a profound stiffness and then a collapse, is also well established. But is there enough knowledge about spike protein acting without the presence of an active viral infection to warrant more research? That's my question. In the absence of proven pharmacological treatments for post-COVID syndrome, let me repeat, there is no FDA, CDC, NIH improvement of any medicine for post-COVID symptoms, the same as acute COVID symptoms. Here's my suggestions. Glutamine is an excitatory neurotransmitter and an energy supply for the body. It's the fuel that white blood cells use when they're fighting infection. It has remarkable effects in healing the intestines, which often in patients with chronic fatigue have leaky epithelial and inflammation. We found some very interesting research about glutamine being necessary to stabilize the dendritic spines on neurons that actually seem to be the location of maintaining memory. So we may see, if there's research enough done, that glutamine stimulates actin to go maintain the structures of the spine where we learn new things and maintain the memories that we've got. 5-hydroxytryptophan has been shown to help anxiety as severe as night terrors in children, a very, very difficult form of anxiety. And unlike serotonin medicines that knock, and keep knocking with their reuptake blockade, 5-hydroxytryptophan supports all 14 serotonin receptors in the systems that are modulating the brain's activity fall downstream. Pomegranate was taught to me by a pesticide sprayer who told me that everyone in his company had cardiac aneurysms after 10 years on the job. And he said they all drink a big bottle of pomegranate juice every day. I tried it and found the inflammation in my own vertebral basilar system reduced. We know inflammation in the endothelium of the vascular system is going to be a problem, one of the long-standing problems. There is research showing that low doses of psychostimulant can help apathy, focus, and discouragement in chronic fatigue patients, 10 milligrams morning and afternoon. There's a very much longer acting stimulant on the market. But when people are in a fatigue state, how healthy is it to overstimulate their brain to try to push their body to climb out of a chronic fatigue state? At the UCSF, there's research that shows that in a chronic fatigue state, patients are in a state of low metabolism, as if they were in a small hibernation, as if they got hurt on a glacier, had to wait a week for someone to rescue them. Of all the parts of the metabolism that slow down, 2 were slowed the most in both the male and female patients. One was sphingolipids, which is extremely important in brain growth and development, and the second was phospholipids, which is extremely important in maintaining cell membranes. Antidepressants, I've already expressed how I'm concerned about starting patients with chronic fatigue and thinking that it's a depression. We need to look at the physical component to it. Hydrocortisone, we know there's low cortisol functioning, but there's complications with the increased rate of infections, although in patients with severe COVID, there was no increased mortality when patients were given steroids to try to slow down the cytokine storm. My favorites are minocycline from my favorite bacteria, Streptomyces. It not only stops inflammation, it has paracrine-like hormone effects. It stimulates stem cells to grow. It opens up the space between the sutures, and many of you may know that the minocycline was part of what led to the development of the tetracycline system of turning individual genes off and on in the nucleus. Clemastine, a surprisingly benign antihistamine drug was discovered by University of California at San Francisco to reverse vision loss in patients with advanced multiple sclerosis. It's not the histamine part of the clemastine that makes the difference. It's a weak anticholinergic stimulators, so that the body realizes that the oligodendrocyte juvenile cells need to mature and start painting myelin. It can give a very quick recovery in brain function, as the speed of neurotransmission goes up tenfold when fiber bundles in the brain, again, are remyelinated. But there's no research in this area to show us whether anything like this is going to be safe or not when we try to consider post-COVID fatigue syndrome. For the cardiovascular and the lung difficulties, we have to decide, and not the insurance companies, whether pulmonary function tests will give us better information about the overall state of somebody's breathing, and we have to decide whether we need some sort of cardiovascular exertion test to determine whether a patient is in a safe functioning level of functioning or not.
I want to tell you about a 9-year-old boy who first came in with a cough in October. He had been playing with some cousins who had come in from out of state for a short family visit. We didn't make much of it until we examined his rib cage and found ribs stiff, and then head hard and hot. So we treated him. He got better. He did fine the month of November. He did good all the way into December. When I saw him next in January, his father had come down with COVID and had to take a week off work. His mother had come down with COVID and had fought being sick for nearly 2 weeks before she went to the doctor and was hospitalized for 5 days. Both kids had been sick, grandmother told me, for 2 days they had spent in bed, but nobody really considered them sick until we examined and found ribs stiff, head hard and hot. This time there was some tension across the front of the mediastinum and that gluey, sticky feeling that I didn't like to find. So we treated him again. He was better February, March. He came back in April, and he'd told me that he had practiced what I told him about not pushing himself in exercise. And he said he found on the trampoline now that he could bounce for 4 minutes before he needed to stop and rest. How much did he used to bounce? He could bounce for hours, he said. 4 minutes. So when he came back in June, finally his liver and rib cage had remained flexible. He only had 2 hot spots left on the lateral frontal bones on either side. He was happy to be roughhousing with his sister again. On the other hand, Mom was still sick. And when Mom didn't feel like eating, her 9-year-old son didn't feel like eating either. Before we wrap up, I want to recommend one book, The Perrin Technique by Dr. Raymond Perrin, an osteopath and PhD researcher in England who spent the last 35 years studying research and treating patients with chronic fatigue syndrome. So lots of case examples, forms to use, and some very interesting techniques. Our osteopathic students may recognize some of them, but lymphatic massage is the most important part of his treatment program. Daily patient self-massage, head and neck down to the collarbones and the thoracic duct, armpits, chest, inguinal and abdominal lymphatics, brushing up every day. He was predicting that there would be a central lymphatic structure in the brain, and it took a while, but it's now been demonstrated that there is some large lymphatic vessels that run in the brain from the front up the sagittal midline, back and around, and coming back underneath the brain. And he recommended adding some massage in this area between the forehead, eyebrows, and the top of the nose. So, in closing, I have to remind us that 4 million American children have already been diagnosed with COVID. And as children go back to school, we're going to be potentially exposing 40 million American students from kindergarten to through 12th grade to the possibility of COVID. COVID cannot be defined by mortality. COVID must be understood to have profound biophysical effects and cardiovascular effects on children of all ages, without regard to how severe their initial period of illness had been. So let's get together and let's break through this quarantine barrier to examining the patient. And let's see what we can do with palpation to help our diagnosis and hands-on medicine to help us heal. It only takes a few minutes to add a little bit of examination, a little bit of treatment, an office visit. Remember that code, G93.3, and let's not forget what good a physician can do, even in times of pandemic. Thank you.